recording?
Oh, yeah.
I'm just kidding.
Yes, it is.
Great. Awesome. Hope that makes a joke. Not really.
In the blooper reel. Ladies and gentlemen. What's that?
Just like make 5 seconds.
Oh, 5 seconds. Sorry. I think you said 5 minutes. Okay, so we're going to go on. Yes.
Yes.
So, Amber, will you give us a countdown?
Hi. I've been practicing.
And here we are with the Mid-Level Show. Welcome back. This is episode 2, season 1 of what will hopefully go to a Friends record-breaking season 10. And I cannot wait. I really did. We were just talking before we started recording about how awesome this concept is. And kudos to my mom and my brother for thinking of this, but a mid-level's perspective on the doctor's note, which is put out by Dr. Rogers, our supervising physician with performance medicine. And we have Amber, Kara, and myself online. Fran is going to be joining us next time, where we are the mid-levels representing all 3 locations. Literally, here we are. I was going to say here we are for the Tri-Cities, but Knoxville is not Tri-Cities, but here we are for representing East Tennessee, including Dollywood, my favorite part. So, today's actually, I really liked this doctor's note. I loved last week's on just the psychiatric symptoms, the anxiety produced by COVID. This week has a flare dedicated towards obesity, the biggest risk factor for developing really symptoms and disease state from the COVID infection. And to me, I don't know what y'all thought, but I'm not surprised. I'm just not surprised by that. Are you guys surprised?
No, because obesity leads to so many other comorbidities, hypertension, type 2 diabetes, high cholesterol. So it didn't surprise me.
Yeah.
I was a little surprised at the fact that it was 6 times higher than, and it was the second greatest risk factor, I think, next to age, elderly being
Right.
at most risk. I found it surprising that it literally was beyond smoking, beyond any pulmonary secondary issue. I guess because we see a lot of the respiratory complications, I thought that would be maybe a second or third,
Right.
but obesity was number 2.
It's nuts. What's nuts to me, what actually did surprise me, was how much of, I have it up here, 5% of obesity is actually addressed and treated and people are on medication for.
Only.
How often, and I've been very lucky to, I've had different experiences outside of being a physician's assistant in different types of clinics. I've been lucky in the sense that I've always been a part of performance medicine because of my family connection with it. It would be unheard of if we did not address, and that's the same, if none of us, including Dr. Rogers, did not address weight in the room. But how often in your clinical experience prior to performance medicine are we really focusing on intervention? I mean, Kara, in the ER, there's no time to,
No, exactly. I can remember, going to the doctor, and if the doctor was obese, then it was kind of a catch-22 if they were to say something. And then really all that I ever got was diet and exercise. What does that mean? There wasn't really any teaching. There was one office here had a nutritionist on staff. And I know of an endocrinologist that also has like a dietitian, nutritionist to teach the patients. But they really, being able to refer to somebody like that just to teach people, they don't understand. You say, oh, low carb. Well, what does that mean?
Oh, just that part. What does that mean? I even had a patient that came in. This patient had gotten a call from her primary care, and all they said on a message machine was, "You have type 2 diabetes. You're going to start metformin. You take it twice a day. We'll see you in 3 months." And she scheduled an appointment to ask us what metformin was, how it worked, why this patient had type 2 diabetes, and what it was. A lot of that is just explaining. And just having the time to sit down and explain, which I feel like is a really good benefit. And what we have is good training within the mid-levels with MPs and PAs. I feel like we're trained to really sit and talk. So that's where I feel like we do a good job. But Amber, what do you think about untreated obesity?
Well, I myself was one of those guilty ones. That was a provider. I was at a neurosurgery office in pain management. And so the majority of my patients there with back pain, whether they were post surgical, I mean, when I say post surgical, they had had surgery in the past, or maybe some that were just there with back pain that had never had surgery, weren't candidates for surgery. Lots of those were obese, and lots of those people weren't eligible for surgery because of their obesity. So they were on pain medications because they were at too much high risk. And there were times, especially prior to working with Dr. Rogers at Performance Medicine, I would almost skirt the issue. It's something that I didn't want to be offensive to
Yes.
these
Right.
patients,
Yes.
and to say, maybe your back pain is because of your weight, maybe your joint issues. And coming to Performance Medicine, Dr. Rogers has really helped kind of hone that skill of addressing the issue
Mhm.
without offending the patient, looking at the metabolic disease process, looking at
Yes.
how we can treat and help these people and all the different avenues
You
that we
bring up
have.
a great point that just that type of patient that you're seeing in the clinic, and a lot of times it's not their fault. A lot of the times with obesity, it's almost like a snowball effect that just builds on
Mm-hmm.
each other. And a lot of it does come from a metabolic syndrome. But a lot of times people have accidents, people have back pain, and getting on medications that contribute to weight gain from that, or not being able to exercise from that, nor having the educational resources to figure out what foods are good. This is totally a side note and not in the doctor's note, but I do find it odd that the healthiest foods are the most expensive. So the
Yeah.
most vulnerable
That's right.
populations, or even too, what's not specifically addressed in this is that another vulnerable population is a socioeconomic, a lower socioeconomic status for developing disease state from COVID. And so really providing what we're trying to do at Performance Medicine is provide educational resources. Yes, saying lower carb is better, and lower carb is better. I don't know, Kara, if you want to go into that since you brought up with that, but if people are listening, we can tell you now why lower carb is better. It's less insulin on board. Insulin loves fat. Do you find that that's how you're explaining it to patients down in Knoxville?
Well, we've talked about my fitness pal with
Yeah.
patients and monitoring it. We'll say low carb is less than 50
Mhm.
a day. And then, keto is less than 20, 25. So we try to give them a number or a goal and
Yes.
a way to measure. Because when you start talking about macros and
It gets complicated. Oh, it gets so complicated. Even too, Amber, are there others? Kara brought up MyFitnessPal. I had a patient come in and talk about the Lose It app. Have you ever
Yeah.
seen the Lose It app?
No, but I had a patient, Carb Manager was one they really encouraged, and I've told other patients about it because MyFitnessPal, I mean, that's the one I always had
Yeah.
used,
Yeah.
and but they said it was very helpful, especially in tracking their carbs instead of proteins, fibers, calories. It was more carb focused.
and
Yeah.
there's another one, Noom.
Oh,
Yes.
yeah.
The Noom coach.
Yes.
And that's supposed to be good. But MyFitnessPal is free. I think you have to pay for a Noom coach. But supposedly you can eat regular food, but it just teaches you how to make adjustments, portions, and choices. So
Yeah.
And if I remember Noom, I could be wrong, but it has a psychological component where you can actually
yes.
track your almost like a journal, a daily journal of, in regards to eating and your feelings.
Yeah. It's so, I feel like knowledge is power. Isn't that like a reading rainbow thing? Like knowledge is power. You do have the power. And the first thing I feel like the first thing is to recognize. And Dr. Rogers brings up the BMI standards of weight versus height. I've even had one patient that was military, and this patient taught me that he actually, we measured in the room the chest width, the neck width, the waist width, and had a very
Wrist.
specific, and it seems so archaic and outdated and kind of a crude measurement, but it gives you an idea of where you're at. And there's always people that will say, well, I know that BMI will says I'm obese, but really, they're just very muscular and very heavy that way. But I feel like recognizing is the first portion. And I feel like most people know if they have a weight problem, but it does become a very emotional aspect to that weight. It's almost like a shaming thing, which we don't like to do at performance medicine. We're not about shame. Shame loves, but the thing about shame that I've learned from Brene Brown and reading her books is that shame likes secrecy.
She's fabulous.
She's wonderful, and she brings up a lot of shame comes from weight issues, but it loves secrecy. It lives in the dark. I almost compare it to like yeast. Yeast loves those like the satellite lesions of like dark, moist spaces where nobody can see and hide, and it grows exponentially. So you almost have to bring that weight issue to the surface to address it, and use the tools that we've talked about today. I don't know. I feel like this is an important one. I really do. If it's not a wake-up call for people to kind of reassess and reassess the values that they're holding during this time, during this crisis, as far as anxiety and in mind, but also with body too. So it's something that needs to be addressed. And I don't know if you guys have any sort of tips that you want to tell our listeners or our viewers today of how they can start with weight management. Do you guys have any tips that have worked?
One thing that going back to his interview with Dr. Branca from last time is that she understands the emotional side of overeating. And like she said, she's lost 100 pounds twice. So in some of our programs, we include visits with her. In our HCG program at weeks 2 and 4, we have visits included with her. And she does Zoom meetings, virtual telehealth. And so people don't have to travel. But I think that's a good idea because people need to understand the emotional side of eating.
Yeah. Oh, absolutely. That's really great. I think that's good. And even too, if you're not part of our programs, if you're listening or viewing from somewhere else, having someone that will keep you accountable and will encourage you at weeks 2 and 4, it doesn't have to come from a licensed therapist. It can come from friends in your support group. And Amber, what do you think? What about tips, for starting? And 2, maybe you can comment. I know a lot of people are saying, well, I can't make it to the gym. My gym's closed.
I know.
I'm looking outdoors right now. There's plenty of stuff that we can do that does not require being in a gym.
That's right. And there's a lot of stuff, even on YouTube. I was very faithful to a gym, and then we had our first child, and that kind of twisted my paradigm. Hold on, sweetie. Me right now. So basically, I started doing more at-home workouts, and so there's so much information, but video workouts for free on YouTube, all different workout levels from beginner all the way to very advanced, with minimal equipment, just body weight workouts. Back to your original questions, when I was with patients, I would, depending on where they were at, I would start by saying, track what you're doing. Like if you're going to focus on carbs, let's start with whatever app you choose. What are you doing in a day? Because some patients don't even realize the amount that they are consuming. And so instead of saying, I want you to do 20 carbs a day, and then they're like dying. They're calling me like, I'm so miserable. I hate you. Not really, but yeah, if they can just have what am I having in a day? Oh, I'm eating 300 carbs a day. Oh my, I'm going to cut down to 150 for this first week. And that's just my personal thing. I try to get them gradually to, then 100, then 50, then, down to their goal. But basically just studies have shown if you write things down, if you track it, you're going to be more faithful to get to that goal.
That's great. It's not like a throwaway answer, diet and exercise, goodbye, see you next patient. Like, hey, write down what you're doing, let us know, and then we work with you to come down. Knowledge is power. I think that's a really great tool, and I hope people take advantage of that if you're listening or viewing right now. And also just know that if Amber can do it with kids in the house right now, you can do it at home too. I'm telling you, you can do it at home too.
At-home workouts are awesome.
At-home workouts are
They keep me sane.
Yes. It's just, there's so much that we can learn from this. And I feel like hopefully we're going to have more positives rather than negatives come out of this. And I think one of them is people are going to start paying attention to what puts you at risk. And for infection condition that we're still learning a lot about, we do know that obesity is linked to poor outcomes. So start today and find your local mid-level like us to talk to, or call and schedule an appointment with Performance Medicine. We can always talk to you over the phone and start giving you some guidance on things that you can be doing at home, because it can start right now.
Yes.
So
Yes.
and yeah, thank you all. Thank you, Kara. Thank you, Amber. I appreciate you both. I look up to you all. I respect you all. I feel very lucky that we're in this very eclectic group of mid-levels, and I cannot wait till next week, where I don't know what the subject will be. Dad just likes to deep throat. I'm assuming it's going to be with COVID. If it's not, that means it's great. We're hopefully getting over it.
Yeah. Awesome.
I hope.
Bye, Andy.
Okay.
Bye,
Thank
Kara.
you.
Thank y'all
I'll see you
so
all
much.
next week.
Thank you. See you next week.